Good evening, everyone. We welcome you all to another OrthoTV original webinar series. Today we have someone from Johns Hopkins University, all the way from USA. He has come specially for us to take a talk on primary complex total hip arthroplasty. He is Dr. DrSavyasachi Thakkar, and this webinar is supported by an unrestricted educational grant from GSK Consumer, the makers of Iodex Ultra Gel. So over to Dr. Thakkar.
Thank you very much, Dr. Bijlani. Let me just share the screen. Okay, you able to see this?
Yes.
Okay, fantastic. So thank you very much and good evening from Washington, D.C., close to Baltimore, where I'm based, Johns Hopkins University and Johns Hopkins Hospital. Given the situation that we are in today, I thought that we could talk about our own form of disaster management, which is planning the complex primary total hip replacement. And either we inherit that disaster, or we sometimes create that disaster. So I thought that we could at least go through some of the management strategies for this condition. Now, as we all know, thanks to Sir John Charnley, total hips have been an extremely successful procedure. And the folks at the Mayo Clinic, including Matt Abdel and Dan Berry, have looked at their 40-year observational study of patients treated with total hips and how patients have done, what is the lifetime revision risk for such a population. And what they found was for about 2,000 hips and approximately 1,700 patients, which were done in the 1960s to 70s, there was a revision rate of only about 13% of patients. And there were two factors that caused revisions for the original Charnley hip. The first was an age-based issue. So the younger the patient, the more likely they were revised. And the second were that there was a gender bias. So men had a higher risk of revision or removal. So these implants have done really, really well. Now, of course, that is Sir John Charnley, but I've made many mistakes in my career. And I've learned from those mistakes to be a better surgeon, to plan better, to avoid pitfalls with regards to total hips and especially complex primary hips. So I wanted to kind of go over some of those techniques that I have developed. Now, of course, one of the things that we always have to consider is where things belong. And that doesn't change whether it's a primary hip or a revision hip. The anatomic landmarks do change and do make it a little bit more challenging. But let's go over the basics of doing a total hip. So positioning an acetabular component, we have to make sure that the bottom of the acetabulum is at the bottom of the teardrop, which is a radiographic landmark. The medial aspect of the acetabular component should be at the level of the ilioischial line or Kohler's line. And then I like to look at the lateral aspect, the superolateral aspect of the native acetabulum, because that helps me judge the inclination angle and how much uncoverage there is of the acetabular component based on my templating and based on what I see intraoperatively. So those are things that I like to keep in mind in terms of placing the acetabulum. Next, I like to template the leg length discrepancy, which can be small for some patients or larger for some patients. And I will show you on how I aim to correct that based on intraoperative landmarks. Then I look at the neck shaft angle, which lets me decide whether or not I want to use a standard offset or a high offset stem design for patients. And finally, I like to look at the horizontal offset, which we know as the distance between the center of rotation to the long axis of the femur. But like every surgeon, I have some tricks which I use. And I like to use the distance between the ischial tuberosity and a point on the femur and compare it to the contralateral side, because that gives me a good intraoperative picture as to whether their offset is adequately restored or it is less or it is too much. Now, I also like to look at the lateral radiograph, especially whether, in dysplastic cases, because that gives you a good clue whether or not there is increased version, either anteversion or retroversion in the femur. For the acetabulum, obviously, you need a good cross-stable lateral radiograph to look at the version of your components and the version of the native acetabulum. And then you can either use fancy software like this, which is the TraumaCAD software, which gives you different components and the positioning and sizes, or you can keep it simple based on the PowerPoint slides that I showed you previously to go ahead and template based off of that. So that was the basic total hip replacement, but what's different about primary, and what makes it difficult, especially with regards to the complex primary hip replacement? So I like to break it down into 3 parameters, as you can see on this X-ray. I like to think about the acetabulum and the acetabular bone stock. Then I like to think about the femur and the femoral or the femoral bone stock to see where things are and what deformity we're dealing with. Finally, I like to think about the soft tissue balance and especially the abductor tension, whether I could achieve this, whether something about the patient makes it unlikely that they will have good soft tissue tensioning. And then you may need to think about adding a dual mobility type cup or constraint or some other method to restore their soft tissue so that they do not dislocate. And finally, we should not forget that there is a balance that we are now appreciating a lot more, and that is between the spine and the pelvis. So the spinopelvic balance, especially in patients that have unbalanced spinal deformity, may play a role in how their hip is managed and how we perform their surgeries. I'll show you an example of that as we move along in this talk. Now, I do primary and revision surgery. So whenever I'm faced with a difficult total hip replacement, I always think about the PAPROSKY classification, because that really gives you a good idea on how to tackle bony issues, especially in the acetabulum and in the femur. So let's start first with the acetabulum. To place an acetabular component into the native acetabulum, you really require 4 things that PAPROSKY classifies and defines. One is you need to identify the center of rotation in reference to where the native center of rotation is, typically at the bottom of the teardrop by the transverse acetabular ligament. Then you need to assess the integrity of the posterior column, which is defined as whether or not you have ischial osteolysis or bone stock, and what is the integrity of the ilioischial or Kohler's line. And finally, you can look at the medial aspect of the acetabulum and see how much teardrop destruction or medial lysis there is to account for that and place the acetabular component. And the goal really is to place a cementless hemispherical acetabular component in the bone stock that you have. So let's look at a pictorial description of that. PAPROSKY really divides this into 3 types, 1, 2, and 3, and that really depends on whether or not there is a rim, whether it's a distorted rim or the rim is completely non-supportive. Now, in a primary total hip replacement, we are trying to achieve a press fit, a press fit of the acetabular component. But sometimes you need to achieve what we call a rim fit, so just around the mouth of the acetabulum. And that is typically associated in cases with PROTRUSIO or acetabular fractures where you're not able to achieve a good press fit to the medial wall of the acetabulum. So those would be cases where you have a distorted rim, but still an intact rim where you can achieve that rim fit. And finally, type 3 is when you have a non-supportive rim, and that makes it very difficult to achieve a good fixation. So in this pictorial description, you can see that the type 1 is a good rim with good bone stock. A type 2 are distorted but intact rims. Type 2A is when you have an up and out deformity, an up and in deformity because of superomedial bone loss. Type 2B is an up and out deformity where you have superolateral bone loss. Type 2C is what I call an in deformity. Typically, you get that in cases of PROTRUSIO, acetabular fractures, or if you put the reamer and you ream too deep. Then types 3A and 3B really deal with high degrees of bone loss and potentially pelvic discontinuity, which you have to reconstruct. So what are the reconstruction options that I like to categorize? Really, there are two types. The first type, which is for the lower degrees of bone loss, is the defect matching. So whatever defect you see, you match that. And the options we have to match that are jumbo cups, allografts or autografts, especially in a primary situation. You can use the femoral head as your autograft. You can do impaction bone grafting with cancellous chips, and you can use augments, but we are not favoring augments as much anymore because we are getting pretty good results with jumbo cups, which are size 66 millimeters or larger in males and size 62 millimeters and larger in females. Now, if you get into the higher degrees of bone loss, so the type 3 defects, you are really thinking about bridging constructs, almost like a bridge plate in a trauma situation, where you may use a cage, a cup cage construct, a custom tri-flange construct, or sometimes you may also have to rely on a combination of that with impaction bone grafting. So this is an example. I know in India we see pretty severe examples of protrusio, but this is an example of a protrusio case that we performed, bilateral protrusio, and you can see the significant protrusion into the medial pelvic cavity and the bone loss that may be associated with it. Now, one thing that I always like to highlight about protrusio cases is that, you know, you have to take your time in dislocating these hips, because if you move too fast and you try and get the hip out with too much force, you can break the femur. So sometimes I will use an in situ neck cut and basically create a femoral neck fracture, move the femur out of the way, and then take a threaded Steinman pin or a Schanz pin and put it into the head and get the head out. And if you cannot get the head out, then you may just take a reamer and use that as bone graft right off the bat without having to medialize. Then I template where I want my cup position to be in these protrusio cases and how much of a medial defect I will have to fill, which in this case was about 9 or 10 millimeters. And I was able to reconstruct this with the native femoral head graft. As you can see on the right side, I was able to restore the acetabulum nicely to the ilioischial line at the bottom of the teardrop. On the left side, I could have medialized a little bit more, but sometimes it's difficult and to assess what the depth is. So you may have to use a drill and assess how deep you're going and how soft the bone feels. The other thing we could do is intraoperative x-rays. I routinely do not get them. I only get them when I'm I'm not having a good rim fit or a press fit for some of these. And I like to use a multi-hole cup for these protrusio cases because, in trying to achieve rim fit, there is a lot of force that can sometimes go through this acetabular component. So to try and get at least 2 or 3 good screws into the anterior column seems to work really well to provide initial stability for weight bearing for these patients. Now, this is a case of traumatic protrusio. So this is a patient that came to us with bilateral acetabular fractures with medial protrusion bilaterally because of an epileptic seizure that he had experienced for the first time in his life. And he was approximately 70 years old. So we had an option of either fixing these primarily and then doing the total hip versus letting things consolidate and gel up and then come back to it and treat it as a traumatic protrusio. So that was the initial injury film. This is the film approximately 6 weeks after the injury, where you can see some consolidation happening medially. The patient was walking, but with very stiff hips. You can see again, kind of at 6 to 8 weeks after the injury. And we have the Jude views on the left side, the iliac oblique view of the left side. You can see that the consolidation hasn't been complete. But on the right side, it's a very nice consolidation. So we counseled the patient and we took him to the operating room for a staged bilateral total hip. This is the view on the left side, where when we got in and we took the femoral head out, we noticed that there was still a decent bone stock in the acetabulum, as you can see with my cursor there. And we were able to use his native femoral head. And in this case, what we did was that we cored out the femoral head and used this autograft, and we still kept this shell of bone that we were able to impact. You will see in the next slide, we were able to impact that into the cavity and provide a medial buttress, at least on the left side, where the consolidation didn't seem as complete on the radiographs. And we were able to use the autograph from his femoral head, and then able to use a multi-hole cup in the appropriate position and reconstruct that defect. And these were his post-operative films. And you can sort of appreciate the shell that we were able to impact in there. We didn't have to do such a drastic thing on the right side, because the right side had consolidated very nicely, and we were able to reconstruct his hips very nicely with this simple, elegant technique. Now, what about acetabular fractures? So this is an example which you look at, and it's a poor X-ray. The bladder is full, the Foley catheter hasn't been placed. There is probably some traction going on, and you may appreciate that there is something going on with the posterior wall, perhaps the posterior column, with a little break in the ilioischial line. In such cases, we typically prefer getting our Jude views, but we also like doing a 3D CT reconstruction just to kind of see where things belong. And with these posterior wall fractures, sometimes you also get this posterior columnar fracture with marginal impaction, and they don't seem to do too well with just fixing them and coming back later to do a total hip. So in those cases, we kind of combine the surgeries, and these are some other views that show you that a lot of the posterior column is involved, even though it is minimally displaced. And the posterior wall is pretty significantly involved with subluxation and frank dislocation of that hip posteriorly. So in these situations, we will do a combination approach, and we will fix the acetabulum first, fix the posterior wall piece, the posterior column piece, and then if need be, do some bone grafting with a rim fit acetabular component with multiple holes once again. And we restrict their weight bearing. We make them about toe touch or 20 to 25% weight bearing for approximately 6 weeks until things have healed up, and then we let them progress from that angle. These are some Jude views which show you the reconstructed posterior column and the lack of displacement posteriorly. Now, this was another challenging case that came our way. Obviously, motor vehicle crashes are pretty bad in India. Here, thanks to the seat belts, due to airbags, due to paramedic support, we don't see such drastic changes, but still we see some of these combination injuries in which you have an acetabular fracture and you also have a pelvic ring disruption. So it's important to recognize both these things, and you need to kind of create a stable pelvic base, then fix the acetabulum, and then do a total hip in that situation to give the best possible outcome. Now, I templated this to have a defect filling type construct and not a defect bridging type construct, because I didn't think that we would need to bridge this defect. And what we began doing is we first began posteriorly, closed up the pelvis with a posterior SI screw, then moved on anteriorly and closed the symphysis, the symphyseal widening, we closed that. And then we fixed the columns, and we were able to use some very nice bone graft from the patient's native femoral head and fill up the medial defect and still put the cup in relatively in a good position at the medial aspect of the ilioischial line. Sometimes in these cases, the landmarks are hard because you fixed things, you fixed the pelvis, you fixed the acetabulum, so things may change. And in those cases, it makes sense to get an intraoperative X-ray. And even though in this X-ray, I saw that the acetabular component is a little bit vertical for what I would like, but due to the excellent stability and the construct being very, very stable, we still left it, and the patient really had a good outcome associated with it. Now, what about cases where there is a failed acetabular fracture fixation? Again, we see a lot of these. where the original surgeon thought that things were well fixed, or sometimes we thought that things were well fixed, and some of these posterior wall fragments can further displace despite you thinking that you fixed the column. And this is a both columns fracture which was treated with a surgical hip dislocation, but still managed to escape and managed to have this post-traumatic osteoarthritis. And in these cases, the biggest thing that you have to think about is the hardware that you're going to encounter. And getting a CT scan sometimes doesn't really help too well because of the scatter that you see. So you have to be prepared with metal cutting burrs and metal cutting devices to try and either cut through the hardware or take it out primarily if it's possible. And in this case, we were able to retain most of it. The point about these cases is that, never be in a rush to dislocate these. And never take out the hardware from the femur before you dislocate, because if you dislocate it after you take the hardware out, then sometimes there is a risk of a fracture. So always gently dislocate, take out all the soft tissue, and then take the femoral hardware out once you have relocated the hip so that you can proceed with the further surgery. Now, those were cases of traumatic injuries and also of defects with protrusio. But what about primary arthritis, which has gone neglected for a long time, and what about defects arising from that? So this, according to the PAPROSKY classification, would be a type 2B defect, where it's an up and out type deformity, less than 3 centimeters of femoral head migration, but you can see a large cyst that is brewing there. And if you don't appreciate or recognize this and treat it appropriately, that could be a problem. So in her case, we used this structural autograft. You could also use a structural allograft if it's a revision situation. And I like to use the 6.5 millimeter pelvic screws to try and fix this. And then the acetabular defect that you have, you basically put your reamer and you just ream through the femoral head and the neck osteotomy that you've made. And it's called a figure of 7 allograft because sometimes those screws look like it's making a 7. And this is what the reconstructed hip looks like. It's sometimes even hard to appreciate the allograft, but there it is. Like an eyebrow, like a sourcil that is sitting above the acetabular component to keep it contained. And we were able to nicely bring the hip down to its native center of rotation and use a multi-hole cup to fix the allograft and to fix the acetabular component to the pelvis. Sometimes, if you have a case like this, which is a failed a percutaneous pinning of a hip fracture in the past, you may not have good bone to try and recreate the type 2B PAPROSKY defect. And in that situation, you may have to use augments with screws. Augments are becoming less popular because, as you can see, even this augment looks a little awkward, sitting a little too lateral, even though the hip looks very good. But you have to create a pretty big defect to get these augments to fit perfectly. So in those cases too, we could use a structural allograft and do a figure of 7 construct as opposed to using an augment. But you do have that at your disposal in case you choose to do that. One thing, some of the older augments, you would have to apply some cement between the acetabular component and the augment so as to prevent metallosis. But some of the newer ones allow you to put a screw through the acetabular component into the augment and then into the native bone, so you achieve primary stability. So that was the acetabulum in terms of defects. Now, when you have dysplastic cases like this, in which you have this valgus neck, you have to be very careful because these cases can have a lot of anteversion associated with it. And with this high hip center of rotation, sometimes it becomes difficult to restore that center of rotation in these cases. And, when we were templating this case, I told my assistants and my residents that, we're going to do a posterolateral approach, and looking at how thin this patient is, we should be able to dislocate the hip in 5 minutes and proceed with our case. And 20 minutes into the case, 30 minutes into the case, we were struggling because of the anteversion that was in the neck and in the acetabulum, that we were just finding it very hard to dislocate it. Now, in that situation, we said that he has a high hip center, and we templated for a jumbo cup a 72 millimeter cup, as you can see, and to correct the amount of anteversion that we had, I opted to use a modular stem. This is an SROM, which would allow some rotational control for us. When we got in there, his tissues were extremely tight. And as you can see, in this case, these cables, which you would think is from a subtrochanteric shortening osteotomy, well, it turns out that he was really, really tight, and putting even the templated stem down, we ended up breaking the femur. So we had to take everything out. We had to cable the femur back together and use the same stem to correct the version and to give him stability. But he's 78 years old, and in trying to bring the hip down to the native center of rotation, we would have lengthened him tremendously, and then we would have done a subtrochanteric shortening osteotomy, which has a high dislocation risk. So we thought that it's better in that case, an elderly patient, to place him at a high hip center. Now, in high hip centers, the problem, obviously, as you can see, is the bottom of the acetabulum is not at the bottom of the teardrop. It's pretty high, but you have a good shelf of bone to contain the hip. It's very difficult to bring the cup to about 35 or 45 degrees of inclination or abduction angle, because you would take off too much bone superolaterally. So these cups tend to be a lot more horizontal, and it's very hard to medialize them to the ilioischial line or Kohler's line. Again, because you are reaming a lot of bone, and it's very difficult for you to keep going deep, 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 and you meet a lot of resistance. So in these cases, the cups don't last that long. The polyethylene doesn't last as long as a good primary total hip, but in an elderly patient, you can afford to take that risk and still recreate good hip biomechanics by giving them a longer neck length. Now, this is an example of a younger patient who had a high hip center, and you can see that she has a dysplastic hip, which is dislocated superolaterally with very poor support superolaterally. And again, with these dysplastic hips, there's a lot of valgus, there is a lot of anteversion into the femoral neck and into the acetabulum. So you need to kind of correct for that. And we like using a modular system. You can also use a non-modular monoblock system to try and correct the version. In her case, we opted to do a subtrochanteric shortening osteotomy. And this is an example on how to do that. So you place the acetabulum into its native center of rotation, and then you place the femoral component into the proximal femur. You make your osteotomy approximately 8 to 10 centimeters into the subtrochanteric region, distal to the greater trochanteric tip. And then how much you have to reduce the hip, so what leg length you have to correct. You basically take off that much bone from that subtrochanteric region and then reduce it and fix it with cables and sometimes with plates. So going back to the example, if you look at the template closely, it's about 28 or 30 millimeters shorter on the left compared to the right. So about 3 centimeters of a osteotomy fragment that I would have to take off to correct it. And you do it gradually, so you see how much leg length correction you get and how much soft tissue tensioning you get. And that's what the final result looked like. Given that she didn't have a good superolateral bone support, we performed a COTYLOIDPLASTY, which is basically you break through the medial wall and try and use then the dome or the remnant dome kind of as your superolateral support with a smaller size acetabular component. There is a lot of anteversion built into this because her native acetabulum was that way. So even though you try and reduce it, they still turn out pretty anteverted. And we were able to use a modular stem, an SROM stem, to try and control the version and give it a little bit of retroversion onto the femoral components so that the combined anteversion between the femur and the acetabulum is between 30 to 50 degrees as described by Dr. Ranawat. The other thing in this case was I wasn't very happy with my rotational stability that I initially had. So I applied this unicortical plate to give it some initial rotational stability with the hopes that if it was bothering the patient, I would go in and take it out. But fortunately, she's done well and she's healed the osteotomy site and had very good correction of her leg length and her abductor mechanism and her offset. Sorry. Now, this is an interesting case of a young woman with pelvic dysmorphism. When I saw this is a weight-bearing standing AP pelvis radiograph. I was a little bit confused because it looks like an inlet view of the pelvis, and there looks like some rotational issue going on the left hemipelvis compared to the right. And she didn't have a very good history. She said that she had some procedure as a child because her hip was dislocating. So some history of dysplasia and some containment procedure done for the same. Now, in this case, I opted to get a CT scan. And this is what it looks like. It's you have no SI joint on that left side. So it's a fused pelvis, an auto-fused pelvis, along with what you see here is a shelf type osteotomy to try and contain that hip. And perhaps there was some infection. Luckily, her inflammatory markers were negative, so we were able to proceed with surgery for her. But we really had to kind of think hard on how to recreate her leg length, right? Recreate her offset, and also give her a pain-free hip, and to try and maximize the use of that shelf, because if that shelf would go, we were basically at risk of going into the greater sciatic notch without anything really to hold the cup in position. So using the 3D CT, I was able to perform 3D bone modeling. And this figure D that you see there is a superior view. So this is the shelf in the orange arrow. The red arrow is pointing to the femoral head. And then this is the greater trochanter. This is what the hip would appear in B if you were going through a posterolateral approach, and what we saw in the patient. These are some oblique views showing you where the shelf is and where the native head-neck junction is to make the in situ neck cut if we need to. Now, this is an intraoperative picture. This is a left-sided hip. So the head of the patient is this way, the foot of the patient is that way. And you can see the shelf right there that we want to keep intact. But what we found was the extreme retroversion of the acetabular component. And in trying to change that, maybe reaming too big too soon, we would lose that shelf. So in that situation, we decided to ream slowly. We decided to kind of put the acetabular component at the level where it should belong, exploit that shelf, use a multi-hole cup, and not go beyond the dimension of that shelf because we didn't want to risk losing that. And using a modular stem, build some anti-version into this case because of the significant retroversion that the patient had, to give her some stability. And we were able to restore her offset fairly well compared to the other side. But her leg length, we were able to give her the maximum possible leg length. Especially, we had counseled her that given an SI joint autofusion, it's only so much that we can mobilize her soft tissues to give her leg length without compromising the sciatic nerve. So in all, this was a good example of cup placement using 3D CT planning. I'm sorry, using also 3D modeling and using a modular stem to correct the version. Now, bridging the gap that I mentioned earlier in the type 3 defects is very rare to find this in a primary situation. So typically I've encountered this in a revision situation. Now, of course, if you have a bad acetabular fracture, you may think about doing this, but try and achieve a good press fit without using these constructs as best as possible, because they don't last very long. So this is an example of a cage that has failed, and you can see the cage protruding medially into the pelvis. And there is really no continuity between the anterior portion and the posterior portions, the anterior and the posterior columns. And you can either bridge this gap or you can perform distraction osteogenesis, which is where you underream by more than 2 millimeters, and you put in a large component, a large acetabular component, and rely on fibrous union medially to achieve some fixation. In this case, we opted to use a tri-flange. This is an example of the defect. This is the obturator foramen. This is the ilium, and this is the ischium that is staring at us. And this is what it looks like with a bone model of the custom tri-flange going into the ilium, ischium, and a little bit into the pubis. These two screws could give you sacroiliac fixation if you desired, through the cup. So they can be as long as that. And this is the example. It was a revision case, so not a primary, but still it highlights the point where you can see the ilioischial line and the medial defect that is created by a broken cage. As you can see here, the cage has failed. And this is a cage cup construct, which we know doesn't work as well now. We like to use a cup cage construct if we are using a cage, because a cage does not have any ingrowth or on-growth surface, whereas a cup does. So if you put in a large cup, then put in a cage, and then cement in a polyethylene, that works a lot better than just putting in a cage. And in this situation, we used a custom tri-flange. And as you can see, it was brought to the center of rotation as it should, but there was a significant amount of bone loss that we encountered in there that we had to account for with this tri-flange. Now that was covering the acetabulum. Now let's move on to covering the femur. So the femur, things are a little bit simpler. You really have to think about three structures: the epiphysis, the metaphysis, and then the diaphysis. And you have to try and gain fixation wherever possible. Of course, the epiphysis is gone because you're going to take the head and neck out when you do a total hip replacement. So PAPROSKY also has a classification for this, and which he shows. So I have some examples here to show you from my revision cases. This is an example of a type 1 deficiency in which there is minimal metaphyseal and minimal diaphyseal bone loss. It's actually completely intact, so you could use a stem of your choice in this situation. In type 2, there is extensive metaphyseal bone loss with completely intact diaphysis. So you could use diaphyseal fixation principles in these methods. This is a type 3A in which the metaphysis is severely compromised, but you have a good diaphysis, especially about 4 centimeters of diaphysis distally to achieve what we call scratch fit, which is a press fit into a femoral stem. This is also an example of a type 3A in which the metaphysis is compromised, but the diaphysis is pretty stout and pretty intact. Now, in this case, if you encounter this revision, please make sure that even if the stem comes out easily, do an extended trochanteric osteotomy, because otherwise you won't be able to put the new stem down the same, down the axis. You will otherwise come out the trajectory of the old stem. So this is another example where there was good cortical bone distally to try and reconstruct. This is an example of a type 4 defect, which is extensive metaphyseal and diaphyseal defect in addition with the widened femoral canal. So this becomes challenging to treat in cases. And again, another example of a type 4 defect. So how do we address femoral anatomy challenges? Well, I mean, really the challenge is in picking the stem. So like we go to a restaurant and we decide which type of stem or which type of food we want to eat based off a menu. We have a menu of different types of stems as proposed by Paul Kanuja and Michael Mont in 2011. And what they described were these various different designs. Typically, when you're doing a primary total hip, you're really sticking between types 1, which is the single wedge mediolateral taper design, or the type 2, which is a double taper, a mediolateral, and an anterior posterior taper. So type 1 stems, I call a metaphyseal fitting type stem, and a type 2 design is a metaphyseal filling type design with some diaphyseal engagement. And as you move into the higher categories, especially in the types 3, 4, and 5, you get some diaphyseal engagement, and you also get some version control. Now, if you want some version control without using a modular system, a very good system is using this tapered spline or cone conical system, which is a Zimmer-Wagner construct. We've really gone away from using these fully coated cylindrical stems because in those situations, there is a lot of stress shielding associated with them. So try not to use them if at all possible. So here are some examples of femoral anatomical challenges. So I'm sure you've seen some cases where you have fracture fixation methodologies like this short cephalomedullary nail, which has failed, and it's created a pretty big metaphyseal defect, without a good calcar, because all this bone seems kind of soft, and you can see this windshield wipering effect of osteolysis. The diaphysis seems to be intact if you keep it intact while you take this out. And again, in these cases, make sure that you dislocate the hip, then reduce the hip, and then take the hardware out before proceeding with the further surgery. Otherwise, you may propagate that fracture distally. And sometimes if you feel like the bone stock is compromised, it may be a good idea just to put a cable distally to prevent fracture propagation distally from that screw. So in this case, we opted to use a modular construct that really does not rely on metaphyseal fixation. Really, the fixation comes in the diaphysis, and you can see that it is bypassed the screw site by at least 2 cortical diameters to give some good diaphyseal scratch fit, at least 4 centimeters or more, and not relying on the metaphysis to give you stability. So a good example of using this, I could have used the Zimmer-Wagner type construct as well for this patient. Here is an example where there is what seems like good metaphyseal bone, but there is some problem in the diaphysis. So this is an old femoral nail that was placed with this femoral fracture, and you're not sure what you're going to run into. So the first challenge was to take this nail out without damaging the abductor mechanism. As you can see, that there is a lot of HO that is formed. So you want to keep that abductor mechanism intact. Once we got it out, we were able to use a type 2 type design, which is a double wedge design, a double tapered design. And we were able to get some good diaphyseal engagement, some good metaphyseal fixation as well, without having to ream too much deeper into the canal. Because if we would have gone into this canal and we didn't get good fixation, my options at that point would have been to use a stem that is really long to engage the distal isthmus or the diaphysis distally, but that's difficult sometimes, or to perform a cemented stem by freshening up the canal to have some good cancellous bone. So those were options that I had kept kind of on the back table, but we were able to achieve this with a type 2 design stem. Now, hip arthrodesis are challenging cases because you don't know what you're going to be dealing with in the femur and also in the acetabulum. You can see this DHS construct where this screw has been in the acetabulum for a very long time and created a big cavity, and all this cortical hypertrophy that has occurred in around the plate. So we really had to use trephines and get these screws out, and took a lot of work. And then we were dealing with defects both in the femur and in the acetabulum. So for her, and also given the fact that it was a fusion and she hadn't used her abductors, we elected to do a few things. In the same setting, we took the plate and screw out. You can see the screw track right there. We were able to salvage some of the head, and we were able to use bone graft, which we were able to pack in there to try and reduce the stress risers that may occur from these massive screw tracks and this hypertrophy. Sorry, let me go in the front again. And we were able to bypass the defect of the last screw by about 2 cortical diameters distally. In this case, we used a conical type stem to achieve some good stability in the diaphysis, give us some version control without using modularity. Because in this case, we had used modularity in the acetabulum, and we used a dual mobility construct to give her additional stability to reduce the risk of dislocation and improve our safe placement zone of the acetabular component. And luckily, she has not dislocated. We gradually went from toe touch weight bearing to 25% to 50%, and now she's weight bearing as tolerated. And she's a young woman, she's about 25 years old. So we want to try and give her as much longevity as we can from this implant. What about this case where you have a dysplastic femur that has had a hip on the other side and has had a fracture, presumably because the components may have been too large. So in these cases, either you can get smaller components if possible, or you can make custom components. So we made a custom stem for this patient, which could interface with the sleeve that was already pre-made to try and achieve some metadiaphyseal engagement and to try and give us version control, which eventually became a rather straightforward case. And hopefully she doesn't go to fracture like the other side. Now, this is another challenging case. This is, even though I presented it as a femoral issue, it's really a metabolic issue. So this is a 16-year-old girl who had some food allergies as reported by the family. And she had a hypocalcemic seizure in her mother's car. And she was taken to the children's hospital, and she kept complaining of pain, inability to walk. And it was dismissed as probably related to hypocalcemia. And nobody really got an X-ray until about 6 months after the incident. And then you see these bilateral femoral neck fractures, which have gone on to non-union on one side, especially the left, and malunion on the right, and this cortical rim around it. So probably the bone has healed in whatever position, and it's going to die. And she was wheelchair bound and couldn't walk. So in this case, we had to employ several strategies. The most important kind of take-home message in this point was to get multidisciplinary care between the pediatrician, the pediatric orthopedic surgeon, the pediatric endocrinologist, the nutrition team. And then, our role is very, very small of kind of performing the surgery, but it has to be a multifaceted approach to tackle these complex patients, because they may have more serious problems as we move along. And in this case, we proceeded to use a ceramic on ceramic bearing surface to give her longevity. And I proceeded to use this compaction broaching type stem. And, it looks like, wow, this stem may be undersized and resting on its collar. It's actually not, because it's compaction broaching. So it's compacting that the bone, the cancellous bone, to try and preserve as much of it as possible, because she is going to need at least 2 revisions, most likely in her lifespan. So we want to try and preserve as much bone as possible in such situations. So this was a triple taper stem with compaction broaching that I used. So we covered the acetabulum, we covered the femur, and now we are coming into the home stretch with 2 issues. One is soft tissue balancing, and the other is spinopelvic balancing and spinopelvic alignment. So soft tissue balancing, this is a case that came to me of a patient who had undergone a revision and had very poor soft tissue balancing. And you can see that she probably has a retroverted, or not probably, but definitely has a retroverted component, and she kept dislocating posteriorly. So we had to tackle that with an acetabular component revision to give her anteversion. And along with that, we had to try and do something about her soft tissues. Now, unfortunately, trying to take the cemented proximal femoral replacement out is very difficult and very traumatic to the rest of the bone. She may end up with a total femur replacement. And the implant used here does not have holes to which you can attach the abductor mechanism. So that became a challenge. So this is a technique described by Leo Whiteside on how to transfer the gluteus maximus muscle when you have abductor deficiency in certain cases. So what he describes is making a superior flap of the gluteus maximus and a posterior flap of the gluteus maximus, and you incorporate some portion of the tensor fascia lata as shown here anteriorly. You lift up the superior flap first, which is shown in A, and then you lift up the posterior flap next, which is shown in B. Then what you do is that you obviously are vigilant about the sciatic nerve. With the hip being reduced, you bring this posterior flap in between the neck and the head and the acetabular component, and you suture it to the anterior greater trochanter. So that's what is shown here. And then you create a trough in the greater trochanter laterally, and you bring the superior flap over that. You can have drill holes that you can use to put some heavy duty sutures, and you can put the superior flap and then put the vastus lateralis over that and kind of interlay everything, interpose everything, so it has a nice myologic seal. Now, in a case like what I showed you, where you don't have a greater trochanter to work with, then what Dr. Whiteside describes is using a cable and placing a cable and then suturing this to a cable. So I ended up using a polyethylene cable, not a metal cable, because I was worried about metallosis and friction. So I used a polyethylene cable and I tacked the tissues down to a polyethylene cable and try and achieve this soft tissue balancing technique. and gave her a hip abduction brace, protected her for a very long time, and then eventually she has declared herself to be stable. If she dislocates after that, we may move to a constrained prosthesis at some point. Another thing to think about dislocation is to always think outside the box, because even if you've restored the offset, the leg length, you have your components in a good position, don't ignore the spine. And this is kind of the final home stretch of our talk in dealing with the spinopelvic issue. And this is an excellent review done by Rand Schwarzkopf at NYU. He's now at NYU, describing the influence of the spinal deformity on the anteversion that you should put into an acetabular component. So this is a normal patient or a normal person who does not have any spinopelvic imbalance. So you are standing and you're sitting, and what you notice are these parameters: the sacral slope, the pelvic incidence, and the pelvic tilt. The pelvic incidence is a sum of the sacral slope and the pelvic tilt. So that number remains constant. And as you go from standing to sitting, notice that the pelvic incidence has remained the same. What has changed is that the pelvic tilt has increased, and along with the pelvic tilt increasing, the acetabular anteversion has increased as well. And this is in a flexible, unfused or non-fused, non-symptomatic spine. So same thing here, you have a flexible, balanced spine, which I hope most of us have. In that situation, when we go from a standing to a sitting position, our native acetabular anteversion increases. Let's say you have a patient that has undergone some spinal surgery and has a spinopelvic fusion, and the spine surgeon did a good job and maintained neutral sagittal spinal alignment. In that case, what happens is that when you go from a standing to a sitting position, the pelvic tilt does not increase and the acetabular anteversion does not increase, because the whole construct has been fused. The spine has been fused to the pelvis. So there is anterior impingement as shown by this asterisk anteriorly. So when they go in a sitting position, the femur will impinge on the acetabulum anteriorly and they will lever out posteriorly. So in these patients, what you want to try and do is that when you put your acetabular component, you want to give them increased anteversion. So you want to put them in between 15 to 25 degrees of anteversion as opposed to between 5 to 15 degrees. So give them some more anteversion so they don't impinge anteriorly. The corollary is true as well. So if you have a flexible and unbalanced spine, what happens is that you lose your normal lumbar lordosis. So you become kyphotic. You kind of hunch backwards. And what that does is that in a sitting position, you are able to maintain your acetabular anteversion very nicely. But in a standing position, that acetabular anteversion is still there. So it's almost like when you get a pelvis X-ray, it looks like an outlet view of the pelvis, not an AP pelvis. And in that case, they are going to impinge posteriorly in extension and they will lever out anteriorly. So in that case, what you want to do is you want to reduce their anteversion to between 5 and 15 degrees as opposed to increase it to 15 to 25 degrees. And you want to prevent posterior impingement while standing. So it's the opposite. And when possible, try and have the spine surgeon fuse their spine first. Now, if you have a rigid and unbalanced spine, again, it could be, you don't know where things are. So you have to try and get these long length films to try and assess where their spine is in relation to their pelvis. And again, they tend to have posterior impingement. So try and reduce the anteversion that you give them. Put the cup in about 5 to 15 degrees of anteversion to try and reduce the anterior instability associated with such cases. So this is an example of a patient of mine who had bilateral protrusio, worst on the right compared to the left. And as you can see, also has some spine issues. And so she had a flexible and an unbalanced spine. So she had a lot of lumbar, kyphosis. In that situation, what our strategy was that we were going to do one hip, which is the right hip. Then the spine surgeon was going to do the spine, and then I would come back and do the left hip. So in planning for that, I gave her some more anteversion despite the recommendations, because I knew that when she will be fixed, then she's not going to be able to get that antiversion. So in that situation, we were able to do the bone graft as I had shown you before, and we were able to give increased antiversion as shown in this 3-dimensional CT scan. Ideally the cup should be around here, but we were able to give it about 25 to 30 degrees of antiversion in the anticipation that her spine will be fused next, and then her contralateral hip will be performed. That being said, I thank you very much for your attention, and I welcome you to come join us at Johns Hopkins.
Hi. Thank you very much. It was an excellent presentation. Excellent means you have tried to cover each and every case there is possible. I think. So I had a few questions. So in the initial cases where you were dealing with acetabulum, what I saw is that in some cases you are using these very short stems. I have never used these short stems in the last 15 years, or maybe they are not available. Which are these short stems and why do you use them?
Typically, these are these compaction broaching type, they're called DePuy actis type stems that have a triple taper. So anterior posterior taper and medial lateral taper, and they have a bevel kind of on the sides, and they have hydroxyapatite coating on them to kind of stimulate more growth faster. So we've started using these, with the hopes that it kind of reduces your stem time and it gives you good fixation to begin with.
So you have now given up on these normal stems which are there, like the, I don't know, what is it called?
The summit, the longer stems.
No, the summit ones are the longer ones, like the Corel.
The Corai, we have switched from using that the Corai from the Corai to the Actis, because the Actis, it is basically a marriage between the Corai philosophy of hydroxyapatite coating and compaction broaching and using like those anterior approach short stems, giving you the same biomechanical stability. So that's why we just go to that.
Because I remember DePuy came out with some short stems. They were really short and they failed very fast.
Yes.
I forget the name.
Yes. Yeah, those are those chili pepper type stems. Even I forget the name. Those we don't use. These are kind of, I think, a little bit bigger than that, but still not as long as the Quran. Okay. The other thing that we lack here in a lot of countries, DePuy makes stems that you can have a distal interlocking screw through, but we don't have that here. Some of the Corai models had that,
So yeah, they have it here. They are called the reef.
Correct. So we don't have that here.
Okay. And besides that, means in the femoral side, you said that you have given up using the solution type stems.
Yeah.
So what is the particular reason for? Do they fail fast?
No, they don't fail fast. I mean, they will be there forever, and they create so much stress shielding that if you have to then redo a revision as a re-revision, you think that you can get the stem out, number one, which is extremely difficult to get out. So you end up cutting it, you end up taking the bone, you end up doing all this stuff, and then you're not left with much to reconstruct because they're just like those thin flakes of bone. So then you have to do few things. You can either do an allograft prosthetic composite, which doesn't have a good track record, or you can do a proximal or total femur replacement, which again, infection risk, and it becomes then kind of a no salvage method.
Very big surgery.
Very, very big surgery.
You also showed a neck femur fracture in a very young girl.
Yes.
So here we are doing a lot of webinars. In fact, I did a webinar 2 weeks back only that Dr. Shushruth Babulkar from Nagpur, he showed his way of doing his osteotomy even for after 3 months, 6 months of neck femur. So the osteotomies are not so popular in USA or in your hospital?
I think that they are, and that's why I kind of like highlighted the multidisciplinary approach. That was what I was in favor of first. That try and do an osteotomy and save it, because this is a problem. One thing that I forgot to include in her case, besides the CT scan, was the MRI, which had shown advanced osteonecrosis, at least on the left side, and some beginning of osteonecrosis on the right side. So we elected to say, okay, at this point, I'm not sure if the osteotomy will work. So give her a total hip, and though she's very, very young, right?
Because in a 16-year-old, how many revisions will she require? If she lives till say 70, 75, she'll require at least 3 to 4 revisions.
Maybe 3. Yeah. So, in those cases, there is, also you could do the like a fibular autograft, like a fibular transfer, vascularized fibular, graft transfer. But I think that the consensus from a lot of quarters was that not going to work in her case, predominantly because people thought, she's malnourished and she may not have the healing potential for that. So they said that, give her a chance with an implant and then we can revise the implant. So I'll be stuck with that revision.
And in the normal THRs or in the protrusio which you showed, so do you have any surgical tips on how you have to do it? Because you have to do it really patiently to remove the head, to dislocate the head. So to go, how much to ream? So do you have any surgical tips for a surgeon who's just beginning to do the THR?
Fantastic question. So, first and foremost, I don't skimp on the incision for those. Those are not those typically minimally invasive hips. They require a big incision. I, right off the bat, take off the gluteal sling from a posterolateral approach because I think that helps you mobilize the femur tremendously. So once I do that, then what I tend to do is that I will gently try and dislocate the hip by taking out, by putting in sometimes even a shank spin inside the head through the neck and trying to use that as a joystick to try and see if I can put axial traction and pull it out. If that's not working or things are fused, I will quickly make an in situ neck cut. Sometimes using fluoroscopic control just to see, I'm not taking off the abductor like the greater trochanter. Once I do that and the gluteal sling is off, it's very easy to translate the femur anteriorly in those cases, sometimes by taking the anterior capsule. Once you do that, you're essentially staring at a femoral neck fracture. So in that case, I will use either a corkscrew or a large threaded shank spin or Steinman pin, put it in the head and lever the head out. And 9 times out of 10, that's worked. If that does not work, then I'll just take my reamer and basically ream into it. Now, how deep to ream in these cases is always a challenge. So in those cases, I never medialized because in my technique, like the Ranawat technique, I medialize first in a normal hip and then I expand the mouth of the acetabulum. In this case, I'm really making sure my reamer stays flush with the mouth of the acetabulum. Don't go any deeper than that. So that's where the depth is maintained. And whatever you have deeper, what I will do is I will use the allograft chips or I will use the autograft from the native femoral head, put it in there and then do a reverse ream to impact it nicely, make it nice and gritty and a little bit of blood in there, and then put the cup, put at least 2 to 3 screws to achieve a good rib fit.
And what about trabecular metal? Do you use it very frequently?
Yeah, so, I will use trabecular metal cups in those situations, like the Zimmer Biomet cups with the multiple holes. Very rarely have I had to use an augment with that. I don't think I had any case to use that. But trabecular metal cups are an excellent source to get that primary stability that you desire.
Okay. And what about the spinal deformities which you showed? So how routinely do you get spine x-rays done when we are doing a THR?
Yeah, that's a fantastic question. So, one of my fellowships was at NYU, where Rand Schwarzkopf is who wrote that paper. So in that institution, they all get these long length films called EOS films, which look at the spinopelvic balance sitting and standing. For every single hip, they get them. But in practice, that's hard to do. It's expensive to do. So the minute I, see a patient who A is either lurching forward or lurching backwards, and B, if I get an AP pelvis radiograph and if they have spinal hardware, then in those cases I get the long length films to see where the spinal balance is, because you may have to change that.
Okay, but routinely, see here in India, the hip replacements are not so common compared to the knee replacements. So we usually don't get these, we usually will get the patients for a hip replacement very late, means they will have a spine problem. So you recommend that supposing if I see that there is a patient who has a lumbar canal stenosis as well as a as well needs a THR or a TKR, do you advise to get the spine surgery done first and then go for the joint replacement or vice versa? How do we decide which one to do first?
That's a tough question. Usually the symptoms are so mixed. Our preference is at Hopkins to do the spine first and then tackle the joints after. So start axially, then go to the hips, and then go to the knees. But there is new literature emerging that if you follow the recommendations given by Schwarzkopf and his paper, that if you put them in that increased anteversion and then you do their spine, assuming that the spine is done well, that seems to have equivalent outcomes. So if you want a quicker fix to the problem, you may do the hips first and then do the spine. But if you want a more reliable kind of, fix the center, then fix the extremities to the center, that's a better, philosophy.
And one last question.
Please.
I completely forgot what I was going to ask. So, how frequently, see, I faced this trouble 2-3 years back. So how frequently, like you showed that you had put plates and everything. So how frequently do you keep these plates and screws ready? Or is it always there as a part of armamentarium in your hospital? So you can just call it for it and open it. Because sometimes you get these weak bones. Like I got this intertrochanteric fracture with a nail cutout. And I had not expected anything in the acetabulum because there was no damage. There was not much damage in the acetabulum. But because it was a long standing, the acetabulum was very weak. And intraoperative, while reaming, I had acetabular fracture. And I had no fallback because we are operating in small setups and we didn't have plates and screws ready. So do you have these plates and screws always ready? Do you order them every time? How do you do it? How do you decide?
Yeah, that's a fantastic question. So Johns Hopkins has various different hospitals. The main hospital is what we call a level 1 trauma center, which means any kind of major trauma can come there. So in that setup, we have everything available. Everything under the sun that you want is available, including other subspecialty surgeons. But when we go into the community hospitals, the smaller Johns Hopkins hospitals, we don't have that. So I have kind of grown accustomed to saying that, if I'm going to run into such trouble, like you said, you have these cutout cases where the bone stock may be weak. If you don't have plates, I tell my hip guys, my implant guys to at least keep a PROTRUSIO cage available, because that is essentially a fancy plate. And if I don't have a plate to go and fix the column, I can at least go ahead and put a cage as a part of any complex primary case. And I will use a cup, then I will use a cage on top of that, and then I will cement a liner in. So I do keep those options available for every single revision and every single complex primary.
And what about these cages which you showed? Do they last a long time? Means like, do they last 15 to 20 years or they fail early?
They fail early, especially if you do a cage, cup construct. And by that, I mean that you put the cage first and then you put the cup on top. If you do it the other way around, it seems to last a little bit longer because you have some primary stability with the cup with some ingrowth. So it tends to shield the cage from the stresses and seems to last a lot longer. So in those situations, if I have no other fallback and I have to use that, I will put in a cup, get a little bit of the distraction type osteogenesis, a larger cup. Then I will put in a cage and then I will put in a polyethylene, and that will at least give them 15 years worth of longevity.
So normally these uncemented normal hips, like if you do what is recommended now? See, here there is a lot of conflict going on. There is a lot of cost factor involved where the patient is paying from his own pocket. Most of them don't have their insurance. So whether to do metal on poly, because I'm always thinking whether should I do a younger patient, maybe he's only 40 years old or 35 years old, and whether should I do a metal on poly, a ceramic on poly, or a ceramic on ceramic. I've never done a ceramic on ceramic. I'm not basically an expert joint replacement surgeon. So I always have the fear in back of my mind that there will be squeaking. So whether to do a metal on poly, ceramic on poly, or ceramic on ceramic.
Yes. So when in doubt in the younger patient, if you can, if your institute or your setup allows it, try and do ceramic on poly at least, because that has better wear rates associated with it. If you do metal on poly, the wear rates are pretty significant and the longevity is about 15 years. Ceramic on poly, the longevity would be about 20 to 25 years, sometimes 30 years. Ceramic on ceramic is obviously the longest, but you're right, squeaking is an issue. The other thing is, sometimes if you put in a cup and you put in a screw, the screw doesn't sit flush inside the cup. It's sitting a little bit off. If you put in a polyethylene liner, you can sometimes, it's malleable enough that it will fit through. But if you put a ceramic liner and if it doesn't sit flush, it is going to crack. So you have to be very careful with those. And we don't do ceramic on ceramic as much as the Europeans do.
So it's much safer to do ceramic on poly. It's a safer
Absolutely.
bet. Safer bet.
So, you know, anyone who is under the age of 80, we are typically putting in ceramic on poly. And anyone above 80, you know, then we can probably go to metal safely. But sometimes these hospitals, you know, what they're doing for us is that they are reducing their inventory. So all we have is ceramic heads all the time.
Okay. And in these trauma cases, which you have shown in this failed trauma, so it's not related to failed trauma, but are you doing bipolars or total hips in intertrochanteric fractures in elderly? Or you're still fixing them with the nails, cephalomedullary or DHS?
You know, I mean, it depends. If it's like a, you know, even if it's an unstable intertroch, you know, we can do a nail, we'll do a nail. But if I'm thinking that it's a peritrochanteric fracture, you know, so a lot of subtroch comminution, lesser troch is off, greater troch is off, and you're thinking that the nail itself, the starting point will just blow everything apart. In those cases, I will do a hemi-arthroplasty or even a total hip, and we'll use the bone graft from the head as a medial kind of buttress, and we will cable it together.
So here somehow that is again two schools of thought in India. So we have, I am somehow we basically want to fix. I have even fixed 97-year-old.
Yeah.
Intertrochanteric fracture, and she's walking after 3 months. With I am more of a PFN A2 type of guy, the synthesis proximal femoral nail, the A2
Correct.
helical blade. I really like
Correct.
that implant. I finished that surgery in less than 1 hour, which I was never able to do with DHS.
Correct.
With less blood loss. So least number of
Correct.
complications. But nowadays I'm seeing that like you also showed, that was a helical blade cutout complication. Yeah. So there are some complications in that also. But
you know, sometimes what I do for those cases is that I will take a bone hook. If I'm not very comfortable with the medial calcar stability, I'll take a bone hook and I will pull the femoral neck into the shaft. So what happens is that the shaft is medial, the femoral neck is a little bit lateral. So even if it subsides, it's hitting something in the bone to try and prevent it.
Okay. It was nice, and I think it's almost 11:30 p.m. for you.
Yes, it is.
Okay.
But nothing tomorrow, so it's okay.
Yeah. Okay. Thank you very much.
Thank you very much, and I'll sign up to the Facebook account.
Right.
You know.
Okay. Bye. I'll send you the.
Take care. Bye-bye.
Bye.